Dr. Rafich here from Vet Triage. We are continuing through this issue of veterinary surgery from November 2024. We are looking at canine paper. Hybrid transarticular external fixation with platelet-rich plasma injection as a treatment for partial calcaneal tendon disruption in dogs without primary tenorrhaphy. And this study comes out of a specialty hospital in Montana, a second specialty hospital in Montana, and another one in Georgia. The objective: to report the use of a hybrid transarticular external skeletal fixator and platelet-rich plasma injection without primary tenorrhaphy for management of partial calcanean tendon disruption in dogs. So this is the implant we're talking about. This is, of course, externally on the actual patient, and then here it is on radiographs. You can see the intricate device that's being used here. It's hybrid because some of it is planar and some of it is circular. It's transarticular, meaning it's crossing a joint. So here it's crossing the tarsal joint. And external skeletal fixation is the entire construct. And then platelet-rich plasma is they take some blood and they take out the platelets and inject the platelets to the area of concern. It's a multi-institutional retrospective study. So those who watch this channel know that retrospective studies are useful, but they do come with a host of issues, usually number of animals, in this case 11 dogs here, so that's a low number, and retrospective studies usually don't have standardization across the board. So all these cases are managed a little differently, so you have some variation there. These cases were from 2019 to 2022 in dogs that had partial non-traumatic calcanean tendon disruption. They had follow-up at 8 to 12 weeks after surgery and then over 6 months after. Results found a median follow-up time 18.5 months, mean time of fixation 9 weeks, return to full pain-free function 45% of dogs, return to acceptable function 45%, and then unacceptable 9%. Complications 45%, which had pin tract complications. So that's where the pins are inserted into the skin and the bones, and so it's very common to have issues with that junction. Conclusion: temporary tibiotarsal immobilization with a hybrid transarticular external skeletal fixator and platelet-rich plasma injection without primary tenorrhaphy can lead to a successful outcome in dogs with partial calcanean tendon disruption. Introduction: the common calcanean tendon is composed of 5 main tendinous structures: the gastrocnemius, the superficial digital flexor, and then collectively the conjoined tendons of the biceps femoris, gracilis, and semitendinosus muscles. So for those of you, again, who are taking boards, these are things you have to know. Chronic degenerative disruption of the common calcanean tendon in working dogs, canine athletes, and household dogs can result in pain, lameness, and loss of performance. Patients with partial disruption may present with acute or chronic lameness and can show swelling of the tendon, pain on tarsal flexion, pain on palpation of the affected portion of the tendon, or hyperflexion of the tibiotarsal joint and digits without a complete plantigrade stance. Plantigrade stance is when the dogs are walking on their heels. So kind of, if you look at a bear, bears normally have a plantigrade stance in the back end, and that's how these dogs would walk with a complete tear, usually. Lesions are classified based on the involvement of the tendons, so either gastrocnemius, superficial digital flexor, or the combination of the biceps femoris, gracilis, and semitendinosus, or some combination. A classification scheme has been reported based on anatomic location and abnormal physical exam findings. These include complete transection, which is type 1. Type 2A is rupture of the gastrocnemius musculotendinous junction. 2B is gastrocnemius rupture with intact peritoneum. 2C is complete gastrocnemius rupture with an intact superficial digital flexor tendon. Then type 3 is chronic tendonitis. Type 2 and type 3 can result in varying degrees of tibiotarsal hyperflexion due to disruption of the gastrocnemius tendon and secondary digital hyperflexion with an intact superficial digital flexor tendon. Biomechanical and histologic data suggest the maximum load of failure for the gastrocnemius is lower than the superficial digital flexor tendon, which could predispose the gastrocnemius to increased incidence of disruption. Radiographs, ultrasound, MRI have been used. Primary tenorrhaphy, so tenorrhaphy is the repair of a torn tendon, is supported by some form of temporary tibiotarsal immobilization to counteract the large tensile forces placed on these repairs during the healing phase. There was a study in normal dogs that found the mean animal strain at the mid-body of the gastrocnemius was significantly reduced after tibiotarsal immobilization with a type 2 calcaneal tibial external skeletal fixator. Immobilization methods used in practice include a calcaneotibial screw, a transarticular external fixator, external coaptation, or a transarticular locking plate. All of these techniques are susceptible to complications, including soft tissue injury or mechanical failure. Randomized control studies and meta-analyses of randomized controlled trials in human literature have shown management of acute Achilles tendon rupture without primary tenorrhaphy did not result in a significantly higher re-rupture rate compared to primary tenorrhaphy. And then platelet-rich plasma, it could be a combination of bone marrow aspirate concentrate and platelet-rich plasma, or adipose-derived progenitor cells and platelet-rich plasma, demonstrating ligamentous healing on second look arthroscopy in 9 out of 13 dogs. Okay, materials and methods. Partial disruption of the common calcanean tendon was diagnosed based on thickening of the calcanean tendon, pain on palpation of the thickened portion of the tendon, and varying degrees of tibiotarsal and digital hyperflexion. Also, pain can sometimes be seen on tendon palpation. Radiographs were evaluated for thickening of the tendon, enthesiopathy or proliferative osseous changes of the calcanean tuber, evidence of calcaneal fracture, fibellar displacement indicative of avulsion of one or both heads of the gastrocnemius muscle. In regards to surgical technique, a regional nerve block was performed, either femoral and sciatic nerves using a nerve stimulator or ultrasound-guided 0.5% bupivacaine. They used I'm just going to list the implants used for the external fixator for those who care about it. 2 84 millimeter full rings, 2 threaded rods, 1 or 2 1.6 millimeter smooth or stopper wires, 2 additional 1.6 millimeter smooth or stopper wires, titanium or carbon fiber 6 millimeter hybrid rod, a hemispherical nut and washer, a variable clamp, or a range of motion hinge. Threaded half pin secured with small SK clamps, carbon fiber connecting rod with variable clamp, and the completed transarticular fixator, which is in this picture right here, underwent final tightening with the tibiotarsal joint at a normal standing angle, which is right here, comparable to the unaffected limb, and then autologous platelet-rich plasma injections. Okay, postoperative care. They wrapped the implant, but not the limb itself. Carprofen, gabapentin, cepodoxime. Fixators were removed 6 to 12 weeks afterwards. Results. Median age, 8 years. Mostly Labradors, secondary Vizslas, and then other breeds. Body weight mean 26 kilograms. Palpable thickening of the tendon, 100% of cases. 91% were localized to the distal insertion of the calcanean tendon on the calcanean tuber. So that's over the calcanean bone, superimposed there. 100% were either type 2B, type 2C, or type 3. Pain on the thickened area or tarsal flexion, 100% of cases. Radiographs showed thickening, 100% of cases, with various degrees of tendon mineralization. And so that's in this image right here. You can see the thickening of the tendon as it inserts on the tuber, as well as that tiny mineralized abnormality within the soft tissue, that's mineralization. All fixators remained stable and no signs of instability. 55% of dogs had lameness of the affected limb with the fixator placed, and the lameness could be mild and intermittent to persistent non-weight bearing. Pain on palpation of the tendon resolved by a month after surgery, and the platelet-rich plasma injection in 100% of dogs. Owner follow-up by telephone, median 18.5 months after removing the fixator. Return to full pain-free function, 45% of dogs. Acceptable pain-free function, 45%. Unacceptable, 9%. Minor complications, 73%, with pin tract drainage occurring in 64% of dogs, and then 9% of dogs, extensor tendinitis. Major complications, 45%, including pin tract infection at 18%, and increased lameness, 9%, late pin tract morbidity at 12 months, 9%, caudal medial tarsal pain, 9%. And I think, again, they're being a bit harsh with calling these major complications, considering that pin tract drainage is like in almost every case. It was in 73% of cases here. So I think at times we have to recategorize minor versus major complications. Discussion. Another study described a 1x1 type 2 external skeletal fixator with 3.2 millimeter stainless steel fixation pins in the tibial diaphysis and the calcaneus, with a 50% complication rate. Another study describes a single transarticular ring construct using multiple tibial wires or pins and a single olive wire placed from the plantar surface of the calcaneus through the cranial surface of the tibia, with a 20% major complication rate and a 60% minor complication rate. Rigid internal calcaneal tibial fixation has been reported, 8% rate of calcaneal tibial screw bending or breakage when supported with some form of external coaptation or an external skeletal fixator. Overall complication rate, 35%. And another study found a 25% complication rate when they used a temporary calcaneotibial locking plate for postoperative tibiotarsal immobilization. Osteomyelitis is also a concern. I would consider that a major complication, osteomyelitis. Given the hard, dense bone structure of the calcaneus and the tensile and distracting forces on it during normal ambulation, it is desirable to avoid transarticular fixation methods that engage the calcaneus if possible. The authors of this study have observed fractures of the calcaneus associated with placement of calcaneotibial screws, calcaneotibial locking plates, and fixation wires that engage the calcaneus. Complications of pin tract morbidity are inherent to external skeletal fixation to some degree. Another study categorized complications with circular external skeletal fixations, either problems, obstacles, or true complications. Problems are defined as those complications that do not need additional surgery and don't affect outcome. Problems include skin irritation, pin tract drainage. Obstacles would be those complications that need operative intervention, like loose pin requiring replacement or repositioning. And then true complications are those that interfere with the original treatment goal, such as neurovascular injury or non-union of an osteotomy or a fracture. The majority of the platelet-rich plasma aliquot was injected around the site of injury. It's difficult to inject more than 0.5 to 1 milliliter. Ultrasound guidance can be used for targeting specific lesions, as well as identification of the paratenin for subparatenin injection for the remainder of the platelet-rich plasma aliquot. So basically trying to say, we're trying to inject this stuff wherever we can that makes sense for the patient. A large meta-analysis of 36 in vitro and in vivo human and animal studies showed mixed findings on the use of platelet-rich plasma. The acceleration of tenocyte healing and others was shown in some studies, and others showed no effect or negative effect on tendon and ligament regeneration. The simple act of penetrating the tendon with a needle, so-called dry needling, has been postulated to induce hemorrhage and cause initiate local tissue repair. A 2-year prospective study in humans with Achilles tendinopathy found limited reliability in diagnosing tendon issues with ultrasound and MRI. Ultrasound appearance of tendon lesions may not correlate with clinical outcome in humans with Achilles tendinopathy. Sonoelastography has been described to evaluate mechanical properties of normal and healing tendons. They're just saying there that physical examination is by far the best method to use to diagnose the condition. So that's it. That's the study. It's a good paper. Obviously, it has the limitations of any retrospective study. You'd like to have more animals, more standardized treatments. These tendons can be very difficult to treat. I think what is missing in this paper, too, is they didn't biopsy the tendon. So what I would have done is, even though they were trying to avoid interfering with the tendon itself with surgery, they assume that the disruption of the tendons here were due to wear and tear, degeneration over time, which is a real thing. But you can't exclude things like trauma that it was just unnoticed, or you can't exclude things like cancers of the tendon, although rare or uncommon. But they should have biopsied the tendons, or at least aspirated the tendons, to get at least a histopathologic answer for what these dogs. That was missing in this paper. All right, we'll see you guys in the next one. For veterinarians, just recognize there are multiple methods to try and treat these conditions, and also it is challenging for pet owners. Give the veterinarian some space, because these are very difficult to heal, and so it's not uncommon to have many vet visits, even with complications and all that stuff. All right, we'll see you guys in the next one. Take care.